All right, everybody. Hello and welcome to Emory Department of Medicine Grand Rounds for October 28th of 2025. I'm proud to introduce Dr. Erika Sigman, who is a neurointerventionalist at Grady and Emory University Hospital. She's co-chair of the Donor Advisory Council at Grady and has been faculty lead for multiple revisions of the hospital's brain death policy, guiding the best practices in end-of-life and organ donation. Dr. Sigmund's also faculty in our neurovascular ultrasound laboratory, and she holds a registered physician in neurovascular interpretation certification, which she uses as a physician interpreter of our transcranial Dopplers for brain death determination. And today she'll be telling us much more about brain death determination. Thank you, Dr. Sigmund.
Thank you so much. And thank you, everybody, for being here and for inviting me to talk about this topic that I think is so important. So basically, the way this came up was, there were new brain death determination guidelines that came out late 2023. So it's created quite a buzz across neurocritical care as well as other critical care realms. And so I appreciate you letting me take you through the high points. Just a little palate cleanser. In my perspective, I grew up in a pretty small town, but in truth, it was really just a suburb of Atlanta, so Dallas, Georgia. But I felt like it was pretty stifling in terms of how remote it felt. And so I was really happy when I got to move to Boston for residency. And I felt like, oh, yes, this is me. I'm living the city life. This is where it's at. And, that persisted when I came back to Emory for fellowship, got to live in Atlanta. And, after a critical care fellowship, my husband and I kind of looked at each other and we were like, we just want the option of wherever we're living, maybe we walk outside and we don't have to see anybody if we don't want to. And so we decided, you know what? We don't have to live rural. We don't have to live in the city. Let's split the difference and live slightly OTP, but get a couple acres. And so kind of went back to our roots and, decided to do some hobby farming. We do a ton of different varieties of peppers, which you can see here, and our dog really enjoys it. Don't feed your dog these kind of peppers, though. They should come with a warning, very, very hot. And as part of that, we decided, let's get chickens. And so now we're up to about 15 chickens. We did have a sad event last year where a Cooper's hawk got into the chick brooder and unfortunately killed several of the little chicks. And in this stage of being very sad and grieving, we said, what makes rational sense is let's go to the farm store and get more chickens. But that day at the farm store, they didn't really have any chickens, but they did have ducks, which this is where everything has sort of gone south. And I've realized that, you should really do a lot more research before you take on trying to take care of ducks. Ducks have taught me a lot, and one of the biggest things is they're not a hobby. They're, at least an hour of work a day, making sure they have water in their pond. They go through water like crazy. They're really messy. We have to clean out their stuff all the time. Um, and, here's them. We let them free range around the yard all day. They go into their coop at night. I think they have a pretty good life, but they've taken a little something from my life. But they've taught us a lot of other things, like bird dogs. We have two bird dogs, two spaniels, and birds can get along. So here's them mingling in the yard, some of the ducks with the two dogs. They will be right beside each other. And now, after months of immersion therapy, they don't mind each other. And the ducks and chickens also taught me that birds of a feather really do flock together, but they can mingle and tolerate each other just fine. You see the ducks over here to the right, sort of off on their own. Back here, you see a different kind of chicken, a crevecoeur, kind of on its own. It tends to be on its own. And then a group of four barred Plymouth Rock chickens that tend to be together, and this little Buff Orpington that kind of goes on his own. But they do mingle and they tolerate each other, all that good stuff. And the one surprise about ducks is they really take your baking to the next level. They add so much moisture in all of your baked goods. And, that's been a really surprising treat and discovery. But, to all the trainees listening, I just want to tell you that I don't recommend getting ducks. I'm on a rampage to do a PSA about this. But more than that is, training is really, really difficult. But I promise, and everybody says this in the future, I'm not saying things will get better, but you will get a lot better. And you will have time in the future to do hobbies you enjoy and hobbies you loathe, like taking care of ducks. So definitely hang in there. No disclosures for my talk. The biggest objectives today, I think I just want to point out the key changes in the brain death declaration guidelines. But more importantly, a lot of you will be potentially doing brain death testing one day, or you have to consult for it. So I think the most important thing is to figure out what are the prerequisites for even moving forward with this. And, how would I evaluate and determine if a patient meets criteria of brain death or death by neurologic criteria? Again, brain death testing, yes, we think about a lot of the times the intensivist and the neurointensivist doing the testing or the neurologist doing the testing, but there's so many people that play a role in advocacy and advocate for accuracy in this testing. It seems relatively straightforward, but there's so many little things that can be missed. And the gravity of this diagnosis is so important to loved ones and the patients and to public trust. You never want to end up in the news as declaring somebody brain dead who then woke up. If you dig into these news articles a little bit, you actually realize, oh, the doctors weren't declaring this patient brain dead. The family interpreted that that's what the doctor said, but that's not actually what was done. And so oftentimes you have to take what the media says with a grain of salt surrounding these cases. But I think we all play a role in helping preserve public trust, whether that's, taking care of these patients, diagnosing the brain death, or when speaking to family members and loved ones about maybe articles that they see in the news. So the guideline was updated actually in late 2023, and it was a group of physicians from the American Academy of Pediatrics, the American Academy of Neurology, Society of Critical Care Medicine, and also Society of Neurological Surgeons. And they got together to revise these guidelines. And so throughout the presentation, if there is something that is new, there will be a yellow star. I'll try to speak about that when it's relevant. If there was something that was a change, there'll be an orange C. And so you'll be able to note those things. But really, why did they want to do new guidelines? Previously and historically, the adult and pediatric guidelines have been separate, but the concept of brain death testing and brain death is the same. There are nuances to various features of the protocol, but the concept and testing is essentially the same. So it makes sense to combine them into one. And then the prior guidelines hadn't been updated in over a decade. And they also wanted to address nuanced scenarios that come up. What about patients on ECMO? What about patients with primary infratentorial injury, like just to the brainstem and cerebellum? What about patients who are pregnant? And what about patients who don't develop diabetes insipidus? Does that count as brain death? And so really these were a lot of the new things that were added, not really new practices that we were doing, but just things that needed to be included in the guidelines. So important terminology, death by neurologic criteria, what the old guidelines referred to as brain death, and we still do use those interchangeably, occurs in individuals who have sustained catastrophic brain injury with no evidence of function of the brain as a whole, a state that must be permanent. And so these guidelines added death by neurologic criteria to be used interchangeably with brain death, really to just jive with the death by cardiorespiratory criteria, the way that most people die, to make it make sense from a medical legal standpoint that this is legal death, death by neurologic criteria, just like you have death by cardiorespiratory criteria. That's still brain death, just another way of phrasing it. The definition of brain death has not changed. They did emphasize a state that must be permanent rather than irreversible. They felt that that really got to the point of, there's not going to be medical interventions that are going to be started that reverse this process. This is permanent. So let's start with a case. So you'll probably want to get out your phones because I will have you do some polling. So this is a 55-year-old man found down in his home upon a wellness check. He is intubated by EMS at the scene. He has no past medical history, but family reports he has become increasingly distant and seldom comes to family gatherings. His exam is notable for non-reactive pupils, no other brainstem response, no withdrawal to painful stimuli, no spontaneous respirations over the ventilator. His tox screen is negative. Chem and endocrine labs are normal. Temperature is 38.1. CT is shown here. And he was admitted 3 hours ago. Can you proceed with brain death testing? So I'll give you the answers on the next slide. So go ahead and if you haven't done Slido before, you can either join, you can scan the QR code or you can join at slido.com and enter this code here, and then you'll be able to see these answers and vote. All right, got a pretty good response rate. I'm going to go ahead and click through this here. All right, so 59% of people say no, do not proceed. Some people say yes, do the apnea first. We got a smattering of other answers, so let's talk about this. So no, do not proceed, but why is that? So the number one thing, whether you're consulting or performing brain death, is you need to make sure three big prerequisites are met before you can either even move forward. The first thing is you have to ensure that there's been permanent whole brain injury. How do we do this? Neuroimaging, right? Neuroimaging showing catastrophic brain injury of the whole brain, not just the brain stem, but also the cortex, subcortical structures, the whole brain. And so in this vignette, the CT that was done, this is not neuroimaging consistent with whole brain injury. How do I know that? Well, I can still all see these folds of the brain, the sulci. I also see good gray-white differentiation here. This is not somebody that, at least from this isolated CT scan, looks like a catastrophic injury. And so in these patients, it's really important to either repeat a scan. Maybe the patient had profound hypoxic ischemic injury that just hasn't shown up yet on CT. Maybe if we wait 24 hours and repeat the CT, we'll see that catastrophic injury. But the other things you want to think about in these patients are mimics of brain death, namely, profound hypothermia has been well described in the literature to mimic brain death, medications or toxins that aren't tested on the tox screen. Our patient in the vignette had a tox screen that was negative, but there's tons of stuff that can also mimic brain death, like baclofen, for example, in massive doses. Things like botulism, variant Guillain-Barré can also make the patient clinically look like they're brain dead, but they would have a normal CT scan as long as there had been no other injuries to the brain. And then certain metabolic derangements, the one we commonly think of is hyperammonemia. We've seen hyperammonemic patients who clinically look like they have absent brainstem responses, not doing anything, but you do a CT and maybe there's some mild edema. And so this would be a CT scan for somebody that has catastrophic injury to the brain. You don't see any gray-white differentiation here. There's herniation. You don't see the basal cisterns. You can't see the folds of the brain here. So this would be a scan of somebody you could potentially move forward with brain death testing. The other reason, number two, is this patient was only admitted 3 hours ago. And so, one of the prerequisites to moving forward with testing is that you've given an observation period to say this is permanent. Now, what is that observation period? Well, we don't have a lot of good, high quality evidence to guide this. The adult guidelines previously had said, you know, we don't have enough information to guide a recommendation here. Now they say if the patient is 24 months or older and it's been a hypoxic ischemic injury, so think about somebody that maybe had a drowning or cardiac arrest, you need to wait at least 24 hours after the injury, but it's unclear how long we should wait for other types of injury. A lot of protocols say anywhere from 24 to 36 hours. And then for patients less than 24 months of age, we want to give a longer waiting period. If there's been a medical or surgical intervention, say a decompressive hemicranie, the guidelines don't really guide us there. They say a sufficient amount of time. And so this is an area where we just have to take it on a case by case basis. Let's try another case. We are going to come back to the prior case, so don't forget that one. I will remind you of the details, but let's go on to another case. You have a 42-year-old woman admitted with a right thalamic intracranial hemorrhage with intraventricular hemorrhage that needed EVD placement. They were intubated for airway protection. The course was complicated by refractory ICP crisis in which they require sedation with fentanyl, Versed, paralysis with a rocuronium drip for adequate ICP control. Despite this, patient progresses to absent brainstem reflexes. Sedatives and paralysis are stopped. Team is concerned about brain death testing and asks for guidance about drug clearance. Their labs are notable for a creatinine of 0.7, BUN of 14, LFTs are normal. Temperature has always been greater than 36 degrees Celsius. When could you do brain death testing? So this will be another poll for you guys. So are you going to, and for those that may have joined late, you can either scan the QR code to join the poll, or you can go to slido.com and enter this session number to join the poll. So you're going to perform the test now, but the patient will need ancillary testing. Are you going to perform after 5 half-lives have transpired for each sedative and paralytic given? Are you going to perform now, but give 5 milligrams of IV Narcan and 5 milligrams of IV flumazenil before testing? Or are you just going to perform the test now and nothing else additionally is needed? This is great. I'm loving the participation. We got so many people. It's a big audience. I feel like I'm like in an arena or something. It's great. Perfect. Great. All right. So yeah, there's some nuances to this. I do love putting in answers or questions where it needs a little bit more discussion. So this is technically the right answer that most of you chose, can perform after 5 half-lives of each sedative and paralytic given. So we'll circle back to that. But the third prerequisite, in addition to one, making sure the patient has catastrophic injury to the whole brain on the brain scan, making sure you've given a time for observation that condition is permanent. The number three thing is, and really the thing that gets, a lot of people, and it's really important to have a checklist for this kind of thing, is that you're excluding all possible things that could interfere with your exam and potentially mimic brain death. So how do you do that? Well, a toxicology screen. You don't have to get one per se, but if there's a concern that there was some sort of toxin ingestion prior to admission, that's when you would want to get a toxicology screen. But remember, not all meds, not all toxins are going to be on that screen. So even if it's normal, it's not entirely reassuring if you don't have another reason why the patient is in the clinical condition that they're in. You obviously want to exclude medications. And, the party line is we give 5 half-lives for anything that could affect mentation or cranial nerve testing or the motor exam. But the thing I really want to emphasize here is that it's not one size fits all for the half-life of a drug. This is particularly important for patients that have been in the ICU for a long time, especially in the neuro ICU. Maybe they've been on sedatives for a very long time. Maybe they've been on paralytics for a very long time. Maybe they've been hypothermic because they've had high intracranial pressures or something like that. Or maybe they've been on paralytics for ARDS. Or maybe there's something else that's going to affect the way they're clearing drugs, their renal function, their liver function. Maybe they're obese, maybe they're advanced age. For all of those things, we really have to think about patient-specific half-lives. And so the longer they've been on these medications, that changes what their half-life is. And so, at Grady, we actually have a pharmacy service or a consult that we require on every single brain death consult, where the pharmacist actually goes through those medications, considers the patient specific context, how long they've been on the medication, were they hypothermic, what's their age, and they use source literature to figure out what is the best estimate of the half-life for this particular medication. And I think it is so incredibly helpful, because I think patients that are on medications for a very long amount of time, you really have to be careful here. Um, so and the other thing I will say is, you may have to, even if you're waiting the 5 half-lives, if you had concomitant hypothermia or something that's going to mess up the clearance, and that patient was on something like fentanyl or midazolam, that's somebody who I would consider supramaximal doses of reversal agents like naloxone or flumazenil. And potentially ancillary testing if you still can't be sure. For temperature requirements, the patient needs to be 36 degrees Celsius or more when you're doing the testing. The adage of you're not dead until you're warm and dead really fits here. Reason being is hypothermia can prevent the functioning of, motor exam as well as your cranial nerve exam. And so patients that have, this is well documented, hypothermic patients can lose their brainstem reflexes. And, that doesn't mean they're dead. So they need to be at least 36 degrees Celsius or more. We don't care if they're having fevers. Most of the time in neuro ICU or neurologic injury, where we don't want people to have fevers, right? That leads to secondary brain injury from glutamate release. But this is the case where we're fine with the high fevers. We don't want them to be hypothermic. And so the guidelines previously had said, more than 36 degrees Celsius for adults previously, but pediatrics, they had said greater than 35 degrees Celsius. So it's a slight change. They made it the same for both adult and pediatrics, and they recommended waiting at least 24 hours with the patient at 36 degrees Celsius if the hypothermia had been 35.5 or lower, something in the range that maybe could affect the cranial nerve function or the motor exam. There's been you want to make sure, in addition to these other confounders, that it's not that the patient just isn't perfusing the nerves in the brainstem, and that's not why you're getting a poor exam or the patient's not breathing. And so the blood pressure recommendations are MAP greater than or equal to 75 and a systolic greater than 100. This is just a slight change for adults when the prior guideline said a systolic greater than 100. This is just because, using a mean arterial perfusion pressure makes more sense from a cerebral perfusion pressure standpoint. And, just to make sure it's not just hypotension leading to this. And then, excluding metabolic confounders. So again, like I said earlier, in general, you want to make sure that your Kim panel, your LFTs, your all of that, your renal function, your liver function is essentially normal, and no derangements there could affect your cranial nerve or motor exam. And so, you know, the one that we kind of see overlooked is ammonia. We know that very high levels of ammonia can mimic brain death and lead to non-reactive cranial nerves. And so, that's a big one to think about. There's been no changes there. In the guidelines, we have always been mindful of all of these things, but there's just been some slight additional guidance in our targets. And so, going back to the case of the patient that was found in the field, that we said, well, we haven't given an observation of permanency, and this imaging isn't consistent with a catastrophic brain injury. There's also a third reason that you wouldn't want to move forward with brain death testing in this patient. His tox screen is negative, but again, not every drug is on the tox screen. And so, could this patient have had a toxic ingestion, such as baclofen, as a suicide attempt? He had become increasingly distant, seldom comes to family gatherings. Those are things that you have to consider. So, one of the great things about the new guidelines is they actually have included a brain death toolkit that you can get from the Neurocritical Care Society. Here's the QR code for it. You'll notice that when you access it, you have to go to purchase, but when you actually do that, you can sign up for an account and it's free. It's not going to make you purchase the toolkit. And there's even a fine print that says, this toolkit is available for free, press purchase. But they've provided it for free. There is a little bit of an activation energy to sign up for it. But the toolkit, the reason it's really cool and the new thing is that they provide some guardrails in terms of what metabolic value should I be looking for and aiming for these patients that I'm doing brain death testing on, and common medications and their half-lives. So you don't have to go look in the literature at the half-lives. They provide it all on a table. The caveat is they don't have the patient-specific or patient context specific half-lives. And so would need to consider that. And so if you've met all of these prerequisites, so just to spaced repetition here. You've proven that there's catastrophic injury on CT. You've given it an observation period and you've ruled out any confounders. It is okay to proceed with brain death testing. Okay. There's been nothing, I'll get into the brain death exam briefly, but there's been nothing that's changed about the exam in and of itself. But there's been some wording changes around what the guidelines say, how many exams we should do. And so in adults, per the guidelines, is 18 years and older, you need at least one exam. That is the same as the prior iteration, but they do have wording that suggests that two exams may be better and decrease the risk of false positives. So depending on where you're working, you need to check your local policies. For example, when I'm at Emory, we have that you need to do two exams in the adult. When I'm at Grady, we have that you just need to do one exam in the adult patient. Either scenario, one apnea test is still okay. So it's two physician neurologic exams followed by an apnea test. Okay. No changes in the recommended numbers of the testing in children. So children for the guidelines or pediatric patients are considered to be 37 weeks corrected gestational age to less than 18 years old. In these patients, and this is same as the prior guidelines, it needs to be two clinicians performing two separate exams, each with apnea testing. And you need to give a period of at least 12 hours in between those exams. I will point out that this 37 weeks corrected gestational age is really important because you don't get appropriate development of the nerves prior to this. So if you try to do brain death testing in a pediatric patient prior to this point, you may not see the nerves responding. For example, you may not see pupillary response, but that does not mean it's because it's not working. It just may not have formed or developed at this point. So it's really, really critical. For the neurologic exam, the Brain Death Toolkit has a great YouTube video showing you the exam, but essentially the components are the same as they've been. You want to show that this patient has no response to visual, auditory, tactile stimuli. There's no purposeful motor response. Now, remember, patients can have really impressive spinal reflexes. Everybody's heard of the Lazarus response, where you have truncal flexion or triple flexion, but absence of motor responses that are coming from the brain, absence of brainstem responses. And so the guideline also has a table link to components of the exam, so you can make sure you're not missing anything when you're doing your exam. So if any part of the exam is not consistent with brain death, you do not proceed to apnea testing. You would give another observation period and repeat the exam. Um, if the exam is consistent with brain death, then you can proceed to apnea testing. Okay. So the apnea test is the same as we've been doing, with a couple of caveats. The core of the test is still the same. You're removing ventilation from that patient while supplying an oxygen source. You're observing that patient for any respiratory activity, and you're monitoring a carbon dioxide level to make sure it reached a threshold that should have stimulated the chemoreceptors in the brain to breathe. The thing that's a slight change, and mentioned this earlier, is that the recommendation is that the MAP is over or equal to 75 during the apnea test, just to make sure it's not a hypoperfusion issue that is leading to absent respirations. It used to be the blood pressure goal was a systolic greater than 100. Now it's systolic greater than 100 and a MAP greater than 75. The test itself is the same. The test is consistent with brain death if there are no breaths and the carbon dioxide levels get to greater than 60 millimeters of mercury and 20 above the starting CO2. In the prior adult iteration, this was an or, so they said, well, the CO2 has to get above 60, or the baseline has to get 20 points above what it was. This is just an additional safeguard to really make sure that we've reached the CO2 threshold that will stimulate the chemoreceptors in the brain. And then the addition of a pH target. So you really want to make sure, again, that you've stimulated these chemoreceptors and that you've created sufficient acidosis that should also stimulate breathing. There's also a clause for CO2 retainers. I won't get into the weeds of that, but if there is a known baseline, it's just the emphasis that you want to be 20 points above that baseline at the end of the test to say, this was an adequate stimulus. If all parts of the neuro exam and apnea are completed and all findings are consistent with brain death, this is brain death. This is death by neurologic criteria. The patient is dead. The death certificate is filled out, and the other processes proceed. That's not a change from the prior guideline. That is all still the same. What about ancillary testing? So the guidelines do talk a good bit about ancillary testing, but just to recap, there's four big reasons you would need ancillary testing. One would be cervical spine injuries that would limit the patient's ability to breathe during the apnea test. Skull base fractures and other facial injuries that could damage the cranial nerves and limit your testing of those nerves. The other reason would be, well, what if you can't perform or complete the apnea test. So maybe the patient's too hemodynamically unstable and you can't keep the MAP above 75 even with pressors. What if the patient has too high of vent settings to do the apnea testing? This is somebody that could get ancillary testing. What if these movements that you're seeing aren't clear, just triple flexion? There's some really wild spinally mediated reflexes that have been described, like the thumbs up sign. That's one that is always wild to see. That would be somebody you could consider ancillary testing in. And if you had a metabolic derangement that could not be corrected, say somebody with severe liver failure that's not going to get better and they got a lot of medications that wouldn't be cleared because of the liver failure. Now, the caveat there is if there are metabolic derangements or other confounders that could be corrected, like waiting an appropriate amount of time or renal clearance, maybe by dialysis, you would need to correct those. You can't use ancillary testing to bypass that. The guidelines actually made a specific statement about this that was new from prior. In the prior pediatric guidelines, they had said, well, you can use ancillary testing to delay if you want to speed up and get around essentially something like hypothermia or medications or an observation period. But now, with keeping in mind that we don't know how some of these ancillary testing could be affected by those confounders. So the recommendation is now you cannot use ancillary testing as a substitute to waiting for medications to clear or waiting for the normothermia to have the appropriate time. So in those cases, you need to correct the prerequisites and then do the exam. The ancillary studies that are accepted for brain death in adults, there are three. Um, Four vessel angiogram. So this would be conventional angiogram, where you see contrast filling here in the ICA, but then you don't see anything filling within the other vessels in the intracranial vault. This would be somebody who's not brain dead. You can clearly see filling within the intracranial vault. So that's the gold standard ancillary test. Transcranial Doppler, not validated in children, but can be used in adults to either show absence of flow or reverberating flow, as shown here, or something called systolic spikes, but just essentially TCD findings of cerebrocirculatory arrest. And then the final thing that can be used in both pediatrics and adults are nuclear medicine studies, where you do a radioactive isotope and you look for uptake inside the intracranial vault. So you can see there's uptake in other metabolically active tissues around that are not supplied by intracranial vasculature, but there's nothing, no uptake inside the intracranial vault. There has been the big change here is EEG is no longer an accepted ancillary test. This is for good reason. The EEG doesn't tell us anything about brainstem activity. It tells us about cortical activity, and so it's not an accepted ancillary test. It hadn't been used like in practice for a long time, at least, since I've been in training and out of training. But the guidelines had not caught up with it. There'd been such a lag in the guidelines. The other special considerations that were included is this focus that hadn't been really done before on families. And one of those things is, it's consent isn't required to do brain death testing unless it's your hospital policy, or there's a specific state statute, of which, in looking into this recently, it doesn't appear that there's any current state statutes that would require consent. There are certain hospitals that require it, but Emory Grady is not one of them. That doesn't mean that you don't need to communicate with the family. More communication there's increasing literature that this helps family and stakeholder acceptance of the diagnosis. We actually encourage that families are, counseled beforehand and are present in the testing, actually. And that's just been, you know, a really good thing, I think, that there's been this push for this. And it's just, I think helped already difficult situation in grieving families. So for neuroendocrine function, the guidelines needed to say something about this because if you look at the Uniform Determination of Death Act, this is an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A determination of death must be made in accordance with accepted medical standards. So this is what the law says about, who is dead, right? And so if you're really reading this, you're saying, wait, all functions of the entire brain. Now, what about patients that have some degree of pituitary function, right? They're not having diabetes insipidus, or they don't develop diabetes insipidus. Well, it turns out that that is a small portion of adult patients that do not develop diabetes insipidus because of variable extracranial supply to the pituitary. And so, incidence of this has been 10% or more in some studies, 20% of patients that don't develop diabetes insipidus. And so, but knowing that there can be extracranial vascular supply to that area and all patients don't develop this, speaking to this in the guidelines, is helpful because, it's showing that our medical standards are that you can still have neuroendocrine function. It's not inconsistent with this whole brain standard of death declaration. The other thing that's mentioned in the guidelines that wasn't specifically commented on before was what about patients who have just posterior fossa injury, meaning infratentorial in the brainstem or cerebellum, uh, but that's where the localized injury is. Sometimes those patients can look brain dead and that they have no brainstem function, no motor response that's coming from the brain. But if you actually look at their whole brain, the cortex, subcortical structures, that doesn't look catastrophically injured. So how do we handle those patients? Well, those patients, it depends, right? If you have this injury just in the brainstem, if the CT subcortically and cortically looks like this, where you still have sulcation, still have gray-white differentiation, that patient can't be considered as a catastrophic whole brain injury. You didn't even meet the prerequisite to proceed with brain death testing. Whereas another scenario, you have progression of the disease process, you get loss of sulcation, loss of gray-white differentiation. This is potentially a scan of somebody who has catastrophic whole brain injury. The injury has now progressed secondarily to involve the cortical and subcortical structures. That patient you can move forward with brain death testing. So you have to be careful in those situations. This is another example in speaking about a pregnant patient who is brain dead or your concern might be brain dead. Um, the guidelines now include discussion of that situation just because it's nuanced. But the practice itself hasn't changed in that pregnancy is not a contraindication to brain death determination. So even if the patient is pregnant, you would, obviously it would be a very multidisciplinary approach. You would want to have a lot of people involved, including legal ethics, OBGYN, all of those stakeholders counseling the family, but move forward with brain death testing and then a multidisciplinary approach to help guide the decision makers about continuing maternal organ support after the declaration. And so this would require legal counsel as well, because there may be variable state laws. And so really, the high yield things here, I think, are this really sums up the new and changed aspects of the guidelines. Really, just they combine the adult and pediatric guidelines into one, which is great for the end user. There were some tweaks made about the MAP goals for apnea and some of the lab criteria for the apnea test. There's more of a discussion about special considerations for patients on ECMO, pregnancy, posterior fossa injury, and a focus on family support. And then emphasis that you cannot bypass confounders like medications and hypothermia with ancillary testing, and that EEG is, not considered a form of ancillary testing. But really the meat of the issue is really the same. You still have to make sure the patient meets your prerequisites. Remember, for space repetition, there's catastrophic brain injury, observation for permanency, and excluding confounders. You still have to perform all parts of the exam and apnea test as you are clinically able, and you still only get ancillary if there's a part of that neurologic exam or apnea exam that can't be completed. Okay. Always with a caveat, there's local hospital policies that might have various standards that you need to look to. The AAN and NCS has come out with a proposed hospital policy to try to unify these things. So that's also in that toolkit. So if you happen to be, going to a place that doesn't have a policy or know of a place that doesn't have a policy, that's a great resource. I'll give you this QR code one more time with the toolkit. But if you enter into this and sign up for the free toolkit, there's a sample brain death policy, like I mentioned. There's even a nice checklist so you can make sure you're never missing anything. This is one of those procedural things that when I'm doing this brain death testing, I always pull out a checklist and make sure I'm not missing anything. This is a diagnosis that has grave consequences and requires the utmost respect for public trust. And so I don't rely on the fact that I do this quite a bit in neurocritical care, but I don't rely on that. I use a checklist. And so don't be ashamed to do that either. If there's questions beyond today, you can of course email me and I'll take any questions that you might have.
Thank you for a very, very thoughtful and organized presentation. I appreciate it. If folks have questions, we have some of the sites are auditoriums. So if you have questions, please either enter them in the chat or you can raise your hand or unmute yourself for the question. I'll kick it off with a question. First of all, thanks for sharing about your chickens and your ducks. That's fun. I have chickens and it's definitely a low maintenance hobby. Good to know to avoid ducks.
Boy ducks.
Uh, I my question was I was curious that in the guidelines you presented that for pediatric patients it insists on two exams by separate providers, whereas not for adult patients. And do you what are the reasons? Is there a physiologic reason behind the difference, or is it more of a social reason behind the difference?
Yeah, it's more of a high stakes reason. These exams, especially in very young patients where, the fontanelles haven't fully formed, like in theory, could there be some, you know, uh, compensation for whatever injury has taken place. And so 12 hours later doing another exam shows that, well, we've given another observation period. It's another examiner. There's been nothing that's changed physiologically about that patient. I think it's less, and, obviously we still do it for patients with formed fontanelles, but that are, 16, 17, right? But it's a higher stakes sort of thing. Anything to reduce the risk of false positives, which there's, um, potentially some evidence that adding an additional evaluator will reduce the risk of false positives. I think yeah.
We have a question in the chat from Dr. Miller who says, thanks for the talk. I'm curious about a MAP goal. during apnea testing, is there evidence that maps between 65 and 75 can produce false positive apnea testing?
Yeah, certainly in patients that are used to a higher MAP goal. There have, or not MAP goal, but think about chronic hypertensive patients. Um, Being at a MAP of 65 may actually be hypoperfusing that patient, especially with any kind of intracranial process that's going on. And so there have been um, potentially false positives related to um, hypoperfusion. I will say just from a uh, in thinking about these things and discussing them with other people, you think about, well, what's physiologically going on. You've reached a point where you have no cerebral circulatory flow, in theory, for, maybe unless it's an extreme hypoxic ischemic injury where maybe you have a little flow, but flow doesn't equal function. Um, you know, by nature of the injury, you're having hypoperfusion to the brain itself. And so my personal opinion there is I don't, it's hard to say that that matters too much, but there's a potential risk of hypoperfusion, especially in those patients that are used to living at a higher MAP. But I think, if you've crossed your T's and dotted your I's in other ways, meaning you've made sure all of your prerequisites are in place, including that catastrophic injury, there shouldn't be a risk of that happening.
We have another question that came in
Yeah.
that although we don't need the family's consent to perform the apnea testing, there are families and folks who won't accept the results of the testing or don't. Um, so how do you navigate
Yeah.
some of that?
Yeah. Um, this is always tough. I think, I'm surprised it happens less frequently than you think. Or than I certainly thought would happen, but it does happen. And it's distressing to the care team. It's distressing to the families. Um, the thing, oh, agree to, you know, just like in examining the patient on a daily, if you were doing a cardiac exam or something like that, we don't ask for consent for that. So I don't pose it as I try to give families, you want to give them some sort of decisions to make, right? Give them the sense of like their shared decision making. In this case, I think talking to them as early as possible about what you're concerned about, like that early counseling of, I am worried that this is going to lead to brain death. Let me tell you what brain death is and how that's different from somebody that's in a coma or vegetative state. This is an irreversible, permanent process where if somebody has brain death, there's no coming back from that. So, doing a lot of counseling ahead of time and laying out, we're going to be doing this exam. We want you to be present if you want to. Allowing them to make the decision to be present or not mitigates this a lot. You know, the other thing you can do, sometimes you get either you get a sense of how uh, family is going to be and if they're going to object to these things. And so in those cases, early involvement of legal and ethics is very important. Um, I think that they're great aids for helping with this. There have been cases where, we've done a test that family objects to, and, with getting ethics and legal involved, a lot of times ethics can um, speak to family. You spend more time speaking to family. Sometimes giving a little bit of time, further conversation, that seems to be a really healing component of all of these issues. And so, at times, for instance, at Grady, where we just do one exam for adults, we've said, well, if you'd like to, get a second opinion, we can do that. So I've certainly served as a second opinion for other people, where the family has not been accepting, but a lot of times it's time, it's counseling, it's support. Um, there's we don't live in a state where there's religious exemption for this diagnosis, but New Jersey is one of those. And, if you have, um, been around for a while, about, uh, you've probably heard of a case where a patient was declared dead in California, and the family actually, even death certificate filled out, but the family got them, transferred to New Jersey for this religious exemption. I don't think that, that's not something you advertise, but there are really, really, um, you know, there's cases that, have been very difficult to manage with that. Um, but yeah, actually, yeah, you mentioned palliative care consult. Absolutely. They can be very helpful, I think, especially if you're getting if you're getting the sense that there's more support than your team can offer. It's not always, it's helpful to have that outside consulting team as well. Um, and so, yeah, that certainly it can be very, very helpful. But, typically time, like most things, is what will help resolve. Um, yes, the McMath case is the one I was speaking of. And again, I'm not a lawyer, but I'm just interested in these various cases. And so that was the young girl that was in California and transferred to New Jersey for, religious exemption in New Jersey.
All right. Well, thank you so much for coming and thank you for sharing your email and your knowledge. We have CME available for the talk, and then we'll put up a link, and we'll see you next week for Medicine Grand Rounds. Thank you so much.
Thank you.